I think the underlying message is that the molecular profiling, especially using targeted approaches, targeted NGS approaches, have become accepted as providing important and often critical information. They certainly provide not only prognostic and predictive information, but may give guidelines to act upon and to devise a therapeutic strategy. One of the examples that was mentioned was the pH-like signature in B lineage acute lymphoblastic leukemia, which as yet is poorly defined, but which is very often associated or typically associated with genetic aberrations and that lead to signaling activation that can be therapeutically targeted. For cost reasons, it seems that in both ALL and AML, there is still an emphasis on the targeted sequencing, and obviously the selection is based on the frequency of the different aberrations in these diseases. Another purpose, of course, is to find targets for minimal residual disease analysis, for serial analysis after the diagnosis and throughout treatment. But I think that in the long run, and this was alluded to, you may miss information by a targeted sequencing approach, either because mutations are important that you haven't thought of, or that you might have a clonal evolution during treatment, which with the appearance of a clone that hasn't been present in the beginning. And this might argue that you should use increasingly whole exome and maybe in a few years even whole genome sequencing when the technology becomes more widespread, and also the biomathematical analysis of the data, which is extensive. These are huge data amounts, becomes more easily accessible. So molecular profiling is here to stay. It is gaining momentum in all of these diseases. The resources, the technological capabilities will determine which methods are actually used. But it has, as shown in the session that I chaired, an increasingly important role.